Bismillahirrahmanirrahim. I am Professor Mohammed Osman, and this is your second lecture, and it's about portal hypertension. This lecture is having three parts. Part 1 and Part 2 about PowerPoint presentation, and the Part 3 we have two videos to show you the treatment of esophageal varices. This is the same picture which I show you. This is a video which I show you in the end of the previous lecture about upper GIT bleeding. It's about bleeding from esophageal varices. I will show it at the end of this lecture also again to remind you and to show you how to treat these varices. Definition of portal hypertension: it is the abnormal increase of blood pressure in the portal vein and its tributaries. Of course, you know that the blood from the GIT, it goes through the portal vein to the liver. It doesn't go directly into systemic circulation. It has a specific circulation which is called portal circulation. It goes through the portal vein to the liver, and then from the liver the nutrients are being sorted out, and then blood goes from the liver through the portal vein, through the hepatic veins into the inferior vena cava. The normal portal pressure is 5 to 7 millimeters of mercury. It's about 8 to 12 centimeters of water. This is the normal range, 5 to 7 millimeters of mercury. Portal hypertension is present when the portal vein pressure exceeds 7 millimeters of mercury. When this is the upper limit, 7 millimeters of mercury is the upper limit. When the portal vein pressure becomes more than 7 millimeters of mercury, then this is portal hypertension, whatever the cause might be. And the bleeding starts when it exceeds 12 millimeters of mercury. The threshold before bleeding is 12 millimeters of mercury. If it goes above 12 millimeters of mercury, you expect the portal vein to start and the tributaries of the portal vein to start to bleed. History: I have given you the history of upper GIT bleeding, hematemesis, and melena, and please go back to the first lecture and know this about this fresh blood or coffee ground blood duration frequency, about melena duration frequency of passing stool, consistency of stool. All this I have given you in the previous lecture. Also, estimation of amount blood, history, dizziness and fainting, symptoms of anemia, clinical examination, rapid pulse with low volume, postural decrease in blood pressure. I have given you in the previous lecture. There is no need to repeat them. Just go back to that lecture and put on these things and listen to them. The cause of portal hypertension: you have the liver as the center. You have prehepatic, intrahepatic, and posthepatic. Portal hypertension is caused by decrease in flow through the portal system, by narrowing or obstruction of the portal system. This can be caused by so many causes. Prehepatic causes portal vein thrombosis before the liver, from the GIT going to the liver. Portal vein thrombosis, if there is clot in the portal vein for any reason. Splenic vein thrombosis: splenic vein brings large amount of blood to the portal vein. It's one of the major tributaries. Congenital atresia or stenosis of the portal vein, if there is narrowing of the portal vein congenitally. If there is extrinsic compression on the portal vein, there is a tumor or there is something that compresses the portal vein, this will lead to hindering of blood passing through the portal vein, and this will lead to portal hypertension. Intrahepatic, inside the liver. The problem is inside the liver, and this is caused by periportal fibrosis, which is caused by bilharzia, and this is the commonest cause of portal hypertension in Sudan. If you go to Mohammed Saleh Idris Center, you will see a lot of cases of portal hypertension, and most of these cases are due to periportal fibrosis, which is caused by bilharzia. And very large center for this is in the Jazeera area, in the area irrigated area in the Jazeera and Managil. These are the major areas which cause portal hypertension by periportal fibrosis, which is caused by bilharziasis. Cirrhosis also causes portal hypertension, but it is not a major cause in Sudan. It is caused by alcohol and hepatitis, viral hepatitis. And this is the commonest cause in Western countries, in Europe and North America. Alcohol is the first cause, and second cause is viral hepatitis. And this causes cirrhosis, and cirrhosis is a more difficult and more complicated disease than periportal fibrosis. Periportal fibrosis is simple. If you can control the bleeding from severe varices, almost the patient will live normal. But in cirrhosis, the liver is damaged. The liver cells are damaged. They die, become fibrotic. But in the periportal fibrosis, there is narrowing of the portal system inside the liver. The liver cells are normal. So if you can control the bleeding from the varices, then the patient can live almost normal life. Post-hepatic causes Budd-Chiari syndrome, which is a hepatic vein thrombosis. Please go back and read about these conditions, all of these conditions, so that you will elaborate or you will increase your knowledge about them. Portal hypertension has consequences, and the main consequence of portal hypertension is bleeding. The most dangerous thing which can kill the patient is bleeding from varices. Portal vein, when the portal blood pressure is hindered, the flow of blood pressure is not normal, it will make back pressure on the tributaries of the portal vein. I said that blood from the GIT will go through the portal vein to go through the liver and then through the hepatic vein into the inferior vena cava. If the portal vein itself or tributaries of, or the branches of the portal vein inside the liver are narrowed, usually the branches inside the liver are narrowed by either cirrhosis or by periportal fibrosis. If they are narrowed by one of these mechanisms, then the portal vein will not be able to go in a normal flow. That means it will make back pressure in the portal vein, and then portal vein blood from coming from the organs, all organs of the GIT is difficult for it to go forward because the space is narrow. So this will the tributary of the portal vein will try to open anastomosis with the systemic system, so that can make a way back to the systemic circulation. And it has some places where this anastomosis will open. You have it in the lower esophagus. The portal vein, a tributary of the portal vein in this area is the left gastric vein. And tributaries from the systemic circulation is the azygous vein. The azygous vein drains into the systemic system, and the left gastric vein drains into the portal system. If the portal system is closed, blood will come, and the left gastric vein will be very large. So it will try to open anastomosis with the azygous vein. So it causes varices, very large veins in the lower part of the esophagus. And these are called esophageal varices. Also, the same vein can cause large veins in the fundus of the stomach, because there is also anastomosis with the systemic circulation here in this area. It can cause fundal veins of the gastric area, and large veins in the fundus of the stomach. In retroperitoneal space or retroperitoneal space, veins from the retroperitoneal organs like the duodenum, like the stomach, the posterior part of the stomach, like the colon, they all have their connection with the lumbar veins. Lumbar veins, they drain into the inferior vena cava. So these veins from these organs, which are near the posterior abdominal wall, or they are adjacent to it, they lie on it, they have anastomosis with this portal system from these organs, have anastomosis of the lumbar veins that drain into the inferior vena cava. So you have veins, varices in this area. Also in the lower part of the rectum, you have the superior rectal vein, which is a tributary of the inferior mesenteric vein. Inferior mesenteric vein is a large vein going to the portal system. So this suprarectal vein gets anastomosis with the middle rectal and lower rectal veins. Middle rectal vein is a tributary of the internal iliac vein, and the lower rectal vein is a tributary of the external iliac vein. So these are systemic veins. Internal iliac and external iliac, they are systemic veins, and the superior rectal is branch of the portal vein. So they anastomose in the lower rectum, and they make large veins which are varices in the lower rectum. This is a drawing of these areas. Here you can see the areas here. This is the lower esophagus. You can see the lower esophagus here. You can see the vein in the lower esophagus, and then you can see the veins in the fundus of the stomach. You see, and these are veins in the retroperitoneal space here, and these are veins around the lower part of the rectum. These are the areas where you will have anastomosis with the systemic, and this is porto-systemic anastomosis. These are the famous areas. Only the famous ones which they cause bleeding in this esophageal area and fundal area. This can cause severe bleeding, and these are the main things of problem, and we'll speak about the treatment of these things. But these ones, the retroperitoneum, because they are protected by the retroperitoneal space, and rectal, they don't bleed, or very, very, very rarely they bleed. They don't bleed. The bleeding here is from these areas of the lower esophagus and the upper stomach. Okay? So we'll speak about the complications and about the treatment, investigation and treatment of these things in the coming lecture. This is the first part of the first lecture, and we'll have the second part of the first lecture. Please go back and read about these things till I prepare for you. I'll give you the second lecture. Okay, thank you very much. Assalamu alaikum wa rahmatullah. This is the second part of the second lecture about portal hypertension, and now we are speaking about complications of portal hypertension. The main complication which can kill the patient is bleeding, and I said bleeding is mainly from esophageal varices and gastric fundal varices. I spoke in the first lecture, the first part of this lecture, about esophageal varices and gastric fundal varices, and bleeding from these two is a major cause of problem for portal hypertension. We have also portal hypertension gastropathy. These are small veins on the mucosa of the stomach. If you look to them by endoscopy, you see them at rounded circles dotted on the mucosa of the stomach. And the larger the number, the problem is greater. And if they bleed, it's very difficult to stop. They cannot be treated by endoscopy. They are treated by drugs only to lower the portal vein pressure. This is the only way that you can treat these things. If you cannot stop them, you have to remove the whole stomach by surgery, and this is a very bad thing. So it is very difficult, and it's very, very complicated thing. Fortunately, it is not very common. It can occur, we have seen it, but it's not very common. Other sites of anastomosis, as I told you, in the rectum and in retroperitoneal, they rarely bleed. These are two pictures. On the left side, you will have, on the left side, this here, you can see these varices, these varices. These are varices, veins, just like grapes. زي العنب, grapes. These are esophageal varices. This is the esophagus, that is, it goes down to the stomach. There in that area, this is the opening going to the stomach here. This is the opening going to stomach, and these are the varices on the walls of the esophagus. And this is on the right side. This is the stomach. This black thing is the scope, endoscope, coming from the esophagus. This is the esophagus. This is the interior of the esophagus. This comes from the esophagus. This is the scope, and then it turns, makes U shape, so that the lens, the camera, can look into the fundus of esophagus. Fundus of esophagus is the upper part of the stomach. It's the ceiling of the stomach, so that he just make U-turn or J shape, so that he can look to the fundal varices. And this is the fundal varix. This is one. In the fundal varix, gastric fundal varix is very large. If it starts to bleed, it is very dangerous for the patient, and it might kill the patient. That's why it is very urgent condition that to treat these patients. These are two pictures also of bleeding vessels, and both of them are from the stomach. This is a gastric fundal varix, and this is a bleeder. You see, this is a bleeder. Very large amount of blood. This is a varix, and this is a bleeder. You see, it is a very large bleeding, can make tremendous amount of blood per minute, and can kill the patient in a very short time, unless you have very active thing to stop this bleeding and to release blood for the patient. Also, complication of portal hypertension, you have hypersplenism. As I said, the spleen contribute to the portal blood by large amount. If there is obstruction or there is hindering of the flow of blood through the portal vein, back pressure will lead to splenomegaly. The spleen will enlarge, and this large spleen will be hyperactive, and this hyperactivity will lead to destruction of the blood cells, all blood cells, RBCs, white cells, and platelets. So you'll have pancytopenia. Hypersplenism will lead to pancytopenia. If you make CBC, you will have low white count, low RBCs, and low platelets, and this is pancytopenia, and this is an indication of hypersplenism. And this is the only indication to remove the spleen in portal hypertension. If there is no hypersplenism, there is no need to remove the spleen, even if it is enlarged. But if the spleen is having hypersplenism, then you have to remove it, because it leads to destruction of the blood cells, all of the blood cells. Also, you will have ascites, you will have hypersplenism, you will have ascites. Ascites usually occurs with cirrhosis, because cirrhosis destroys the liver, and the liver function will be deteriorated. So the patient will have ascites, because the manipulation of the water will be less, and then the body will keep water inside, and it will lead to ascites. Also, destruction of the liver cells and deterioration of the liver function will lead that the byproducts of the metabolism will not be completely dealt with, especially the ammonias and these things, and this will lead to encephalopathy. Encephalopathy will affect the brain, and this is a very bad thing. The function of the brain will deteriorate, and the patient will go in and out of coma. So these are very bad things. These last two ones, they are caused by cirrhosis. Investigation of the portal hypertension. You do CBC. I told you how to differentiate between new bleeding, active bleeding, recent bleeding, and chronic bleeding by looking to the hematocrit. You go back to the lecture and listen to the explanation. You do the liver function test, because the main organ affected is the liver function test. Usually in periportal fibrosis, the liver function test is normal, but in cirrhosis, the liver function test deteriorates. You measure the prothrombin time and INR. You check the renal function tests, because also bleeding will lead to deterioration of the renal functions. You make upper GIT endoscopy, and upper GIT endoscopy is diagnostic and therapeutic. You can diagnose from where the bleeding is coming, and then by the endoscope you can treat the condition. If it is esophageal varices or gastric fundal varices, or even ulcers in the stomach or ulcers in the duodenum, you can treat it by endoscopy. You do abdominal ultrasound to see if there is enlarged spleen, the size of the portal vein, the liver, whether there is cirrhosis or not, or portal fibrosis. If you can see all this is the splenic vein and the splenomegaly, and إذا كان في hepatomegaly. You can see all these things by ultrasound, and this will help in the diagnosis. Then the treatment for portal hypertension. In the emergency, the first thing you want to do is to keep an open vein, because the active bleeding will lead to collapse of the vein, and it's very difficult for you to find the veins later on. So you have to open put two large IV cannulas in the veins, and give IV fluids, any available IV fluids, to keep the veins open. And then take blood for investigation, grouping, and area blood preparation. Grouping, cross-matching, and even an area blood preparation. And then give vasopressin or somatostatin. This vasopressin, somatostatin, to decrease the portal vein pressure. These are drugs specifically to decrease the portal vein pressure, and decrease the portal vein pressure, hoping that it will go below the threshold of bleeding. We said that 12 millimeter mercury is the threshold. If it goes above it, it will lead to bleeding. If you can bring the portal pressure down, then the bleeding will stop. You give vitamin K, because the liver function deteriorate. It will lead to the vitamin K will absorption of vitamin K will lead to, it has some function with the clotting mechanism, vitamin K. So you give vitamin K so that it will improve the prothrombin time and these things, so that it will make the bleeding less likely. And then give blood when the blood is available. When the blood is available from the blood bank, and then give blood, because this is the main treatment at this time. If the bleeding continues, it doesn't stop, even if you give those two drugs to lower the portal hypertension, then you insert a Sangistachian tube or Minnesota tube. These tubes to compress on the gastric fundal varices and esophageal varices to mechanically stop the bleeding. They compress these veins and prevent them from bleeding. This is a mechanical way to stop the bleeding. Do upper GIT endoscopy within 6 hours of diagnosis and treatment, so that you will diagnose the case and make appropriate treatment for it by endoscopy. Then when you treat the patient with endoscopy, the bleeding is stopped. Then you don't discharge the patient directly. You keep the patient in the hospital for at least 2 hours to observe and to know that the bleeding has stopped. Then after that you discharge the patient, and you book the patient for repeated endoscopic treatment for the varices, fundal or gastric varices. You bring the patient in Ibn Sina hospital. We have in endoscopic unit where these patients come regularly to be injected, or to have banding to close the varices of the esophagus or stomach. And then follow up in the portal hypertension clinic for progress of the condition. Even after the closure of the varices by endoscopy, the patient has to follow in the portal hypertension clinic for life. It is long follow-up. This is Sangistachian Blackmore tube. You can see that it has 3 ports. This one, and this one. 3 ports. This one here is for gastric suction. This one, it is for gastric suction. One of these, this one for balloon of the stomach, and maybe this one for balloon of the esophagus. You see, inflate the balloon of the esophagus, balloon of the stomach by one of these these things, and this for suction of the blood from the stomach. This is Minnesota tube. It has the same value that, but it has 4. 1, 2, 3, 4. This for the balloon. This for the balloon, esophageal and gastric balloon, and this one for the gastric section, and this one for the esophageal section. Esophageal section usually in this area between the two tubes. We'll have an opening here in the tube, and it can suck blood from the esophagus. Also, the bleeding can be from esophagus. It can suck blood from the esophagus. Go back and read about the use and the difference of these tubes and how they are, the benefit of this over the second tube. This is chemotherapy. I will show this video in a separate after this lecture. After this second part, I will show you this is chemotherapy for severe varices. I have shown you the tube this video before, and I will show it again. And this is banding, also of severe varices. I will show it to you again. Injection of histoacryl for gastric. This is for gastric fundal varices. This one is for gastric fundal varices. This is for gastric fundal varices. Histoacryl. The difference between histoacryl and this 5% isanolamine. 5% isanolamine will stop the bleeding by mixing with the blood and causing clotting of the blood inside the vein. So it closes the vein by a clot. Banding will compress the vein. You are going to tie the vein by a band. So you will close it by tying it. And the histoacryl for the fundus varices, because the fundus varices are very large, they have very high flow of blood. And if you use histoacryl, it's very difficult to stop them because high flow. They will not give the. If you use isanolamine needs some time to make the blood clot. But this very high flow, and it will not allow time for the isanolamine to cause clotting of blood. So they use histoacryl. Histoacryl, when it is injected inside the varix, it will form something like a gum. There's some. So it will occupy the veins inside. It closes it from inside. It actually to occupy the vein and prevent blood from entering into the vein. So it closes it by occupying the vein. If you have a refractory cause, you try making endoscopic, you make in the second tube, you try to stop the bleeding, but the bleeding does not stop. You can have some cases. Fortunately, we have 1 or 2 in the past 15 or 20 years in Mohammed Saleh Idris of these refractory cases. Almost all of the cases we can treat them by endoscopy. But if you cannot treat them, you use TIPS. TIPS is transjugular intrahepatic portosystemic shunt. This is by endoscopy. You go through these veins till you reach the inside the liver, and then you make anastomosis between the portal system and the systemic system inside the liver. Inside the liver, portosystemic shunt, inside the liver. We say that there is systemic anastomosis in the abdomen. But now this you make portosystemic shunt inside the liver. And this is a very difficult treatment. Actually, you don't have this treatment in Sudan. Or actually, this TIPS usually is for, usually if you want to do these TIPS, to make the patient wait for transplantation, to transplant the liver. You give him transplantation. He is waiting, there is a waiting list, and we make these TIPS so that the patient will wait till we find the liver for him and make transplantation. You see, we don't have yet transplantation in the liver. We have a center that is built, and very soon we are going to start transplantation. surgical treatment for these refractory cases, the cases which cannot be treated by endoscopy, the patient continues to bleed. Surgery for this was available previously, but the mortality rate of the surgery of these cases is 89%, almost 90% of the patient who has surgery, they die on table. The very high mortality, and because of this is abandoned. They left it. In the West, they stopped doing these operations because the mortality is very high. And usually the cases which are refractory for treatment, usually these cases are of cirrhosis. Case of cirrhosis. In Sudan we have bilharzia, and so these refractory cases are we don't see them in Sudan. Almost all of the patient with treatment with endoscopy successfully. We don't have TIPS in Sudan yet, and we don't have liver transplantation in Sudan yet. We will start this very soon, inshallah. This child's classification, I bring it for you here because it's very important, and you go and read about it. This divide the patient of liver problem into A, B, and C. A is the better one, going towards the normal, and C is the worst one. And you can classify them, or you can diagnose them by the bilirubin, albumin, ascites, and encephalopathy, and nutrition. You go and read about this and try to understand it, and read about it, literature in the internet, and you'll understand it. This is the end of the second lecture, and please go and read about it more. Don't depend on this only. Read about it more, and I hope you will find things about it, and you'll find it useful. Thank you very much. On this on the previous lecture, and I talked about it, and just I give it now to you just to remind you again of the very serious bleeding in these cases. Very tremendous, very alarming, and really the patient needs help, and you have to be very careful and very alert of treating such patients, because these patients can die because of this severe bleeding. Now you can see the endoscope. He injects the vein, and the vein now is the blood from the vein is stops. You see the vein here? The vein stops. The bleeding stops. Assalamu alaikum. You can see the bleeder here. You can very clear, and you can see this is a bleeding. This is a bleeder. Severe bleeding, and this is a scope. This white one is a scope. You see, this is a scope, and these are the strings for the band. You see. Now he's trying to make these are the bands. You see the bands? These are the white things. He ligated the vein with these bands. You can see them very clear. The bands are very clear, and he can ligate the vein with the band. Two bands. You see? You can see the two bands.
Hi, my name is Ala Sharara. In this short video, I will review with you the endoscopic management of gastric varices, namely the endoscopic obliteration or obturation of gastric varices. In this slide, I have listed for you some important points regarding gastric varices. It is important to note, however, that the management of gastric varices remains a therapeutic challenge. Because there are a few controlled clinical trials, the strength of the evidence underlying the guidelines for their management is weaker compared with their esophageal counterparts. It is important first to start with a quick discussion of classification of gastric varices. There are a few proposed classifications, but the one that is most used in practice is the one proposed by Sarin, which is shown here, and is the one recommended by the Bovino Consensus Working Group. It classifies varices on the basis of their location and their relationship to esophageal varices. The type 1 varices extend along the lesser curvature and account for about 70% of gastric varices, and those are usually managed as esophageal varices. Gastroesophageal varices type 2 extend along the fundus, while isolated gastric varices can be seen in the fundus or at ectopic sites in the stomach or the first part of the duodenum. The principle of variceal obliteration with tissue adhesives is essentially simple and is similar to the conventional sclerotherapy. This is a list of the accessories that are needed for use. Tissue adhesives such as N-butyl-2-cyanoacrylate or cyanoacrylate for short are preferred over the usual sclerosant because of their rapid polymerization and contact with blood or living tissue. Of note, N-butyl-2-cyanoacrylate is commonly used in Europe and Asia, but is not available in the United States. However, a similar agent, 2-octyl-cyanoacrylate, has been approved by the FDA for skin closure and has also been used for the management of gastric varices. One of the techniques used for obliteration of gastric varices employs the so-called sandwich technique. First, the dead space of the injector catheter is determined, usually anywhere between 1.5 and 2 milliliters, and then the injector catheter is filled with lipiodol, followed by a combination or mixture of cyanoacrylate and lipiodol at 1:1 or 1:1.5 ratio, followed by a volume of lipiodol. Following penetration of the varix, the injector volume can be emptied into the varix, the needle is withdrawn, and then saline flush is used to empty out the injector catheter. This step can be repeated for every injection as needed. Another technique is the pre-filling of the injector sheath with cyanoacrylate and lipiodol mixture. This can be useful for repeated injections or in the case of active bleeding, and the catheter can be flushed between injections with saline. The patient shown in this video is a young woman with myelofibrosis and myelodysplastic syndrome with massive splenomegaly, portal vein thrombosis, and portal hypertension. She had a history of esophageal variceal bleeding in the past, controlled with band ligation and medical therapy, and recently presented to an outside hospital with massive upper GI bleeding, where an upper endoscopy noted minimal proximal esophageal varices but multiple large gastric varices. These large varices are identified on examination today. The options for endoscopic therapy here include obliteration with tissue adhesive and possibly band ligation. The use of traditional endoscopic sclerotherapy is ineffective because gastric varices are usually associated with a gastrorenal shunt or a gastroinferior vena cava shunt, resulting in rapid outflow into the systemic circulation, and any sclerosant that can be injected will rapidly escape into the systemic circulation with the delayed onset of local thrombosis. Band ligation can be effective in acute management, however, studies have shown that it is inferior to tissue adhesive injection because of its higher rate of rebleeding. In this case, we decided to do obliteration using tissue adhesives. As soon as the needle is primed with the injection solution using the sandwich technique, then the varix can be approached and punctured, and the volume inside the sheath of lipiodol followed by lipiodol and cyanoacrylate as a mixture, and then lipiodol is injected inside the varix, and the needle is withdrawn into the sheath and retracted, and the needle can be flushed with saline. Upon retraction of the needle, there is sometimes a little bit of oozing, which is usually transient. There has been reports of rare episodes of the needle being stuck inside the polymerized glue, and this depends on how quick the polymerization happens. So it's preferred to have a not too quick polymerization. There's minimal oozing, and this is stopped, and one can see the varix here has been obliterated with some evidence of glue particles that are exuding from the injection site. A week later, that varix has been obliterated, and the examination shows the other two variceal columns in the fundus, which are injected and obliterated using the same technique in sequence. Between injections, the needle is withdrawn and flushed completely with saline and primed again with the injection material after using the sandwich technique. 10 days later, examination shows that these varices have been obliterated. The varices can always be seen. However, they now have a hardened cast inside of them because of the polymerization of the glue, and this is demonstrated here by touching the varix with a blunt biopsy forceps here, showing the hard nature of the variceal content. Upon close inspection, we can see that on either side of this large obliterated varix, there are still parts that have not been completely obliterated. This will be demonstrated here with the blunt tip of the injector catheter touching upon that end of the varix, showing its soft nature as compared to the hardened, obliterated part of the varix. It was decided, therefore, to inject this part of the varix with the cyanoacrylate and lipiodol combination. The varix is punctured and is injected with the mixture. There is movement here, and the needle has been ejected from the varix with some active bleeding. This was controlled by repeated injection, and obliteration of this part of the varix is also achieved with the injection. A final and important point in the tissue glue obliteration of gastric varices is to limit the volume of injections and to use a standardized injection technique and regimen to avoid accidental obliteration of the endoscope channel, as well as local and systemic